have given a nice topic to me, which is a very practical one, and that's how to practice regional anesthesia in a peripheral hospital. Okay. So all of us know that 68% of the Indian total population live in rural areas, and half of them living are below poverty line. And unfortunately, they are struggling for better and easy access to healthcare and services. Rural surgery is defined by some as multi-speciality surgery done under constraints. This is a place where I come from. It's placed in the northern side of Karnataka, and that is the demographic statistics. And most important is this anesthetist surgeon ratio. So every day, one anesthetist has to run around attending calls for 10 surgeons. If they are surgeons, it's okay, but gynecologist is very tough, because all are distresses. Either it's an obstetric distress or a maternal distress or a distress that the patient will deliver. They are so behind us that we have to come. Okay. This is the statistics of how I do my cases. Major are obstetrics, the next is orthopedics, general surgery, and other specialties do come. So anesthetic technique wise, general anesthesia, all the techniques are practiced, but if you can see this, if you combine all these three pillars, it becomes more. So more than 50% of my work is regional anesthesia. So a rural doctor has to satisfy the three P's, that is the patient, the public, and of course you have to satisfy your own profession. So you have to deliver what are the cardinal features of quality. Whether the patient is from a rural area or an urban area, the value of life is the same. So you can't take anybody lightly. So you have to provide the best possible clinical care. It has to be efficient and it has to be cost effective. And lastly, the patient has to be satisfied and he has to accept your techniques. What are the limitations and scopes of a rural person who practices in a peripheral hospital? Technical problems. If at all we face technical problems, we can't get immediate services. If there is a failure in current or if any of our equipments fail, the services are quite poor, and especially if you are doing some complicated case, then you are in soup. You have to own your professional skills and you have to be much better. You have to choose such a technique which is very safer to the patient. Luckily, we are not much into legal problems because our patients respect us a lot. They consider us next to God, though from the inner side we know we are not. Okay. 20 years ago, when I went to my place, the facilities were very poor. There were about 20 nursing homes. There was only 2 boils operators, anesthesia machines. Remaining places, this was my friend. So I had to carry everything except the table and the light. I had to have ambu bags, laryngoscopes, then red rubber tubes. I just discarded it about 2-3 years back because all had stuck together. Okay, so that was my thing, and I used to go around in two-wheeler. So whenever I used to go, if somebody I used to meet, just ask, "Are you going out of town?" I used to say, "No, this is my kit." But slowly I had to insist those people that you have to keep some equipments. Now I go with a backpack. Now they ask, "Are you going for trekking?" That is the problem. So equipments was next. Very few equipments. They used to have cylinders, oxygen cylinders, but they were empty. They had suction machine, but they were not working. So these are the problems, and fortunately I was good in mechanics also. I used to repair a bit of suction machines, cauteries and all, but I couldn't fill the empty cylinder with oxygen. Then monitoring was very difficult. I had to depend on my clinical ability of having my hand on the pulse, look for respiration, and look at the breathing. So what are the challenges of regional anesthesia in peripheral hospitals? The first challenge is you have to convince the surgeon. There are very nice ways to convince the surgeon that I'll tell you later on. You have to provide good patient comfort, and always safety comes first. And because we don't have plan A, plan B, plan C, we will be having only one plan, that is regional anesthesia. So you have to increase the success rate. So general anesthesia is very challenging in our place because again the facilities are less, monitoring standards are low. I don't tell it is now. It has we have gone way ahead and probably we are better than many of the big places. Secondly is when you are in crisis, if you have to call for help, you have hardly any people. One of my colleagues is here, he is busy somewhere, he can't leave his case and come. So usually sometimes we plan if there is a difficult case so that we plan our schedule. Investing on equipments is one of the things, and if you invest, it is going to give you a lot back. Nursing quality and care, what I have to say is it's very poor. In fact, our nursing personnel are actually maid servants. They have to work in fields or at home as maid servants. They come to the hospital, wear a white sari and become sisters. So we can't expect much from them. And the qualified nurses don't come to our place because they expect high salary. Then there is a financial constraint for the people, so we have to be even very careful about their pocket. Government services are poor, caseload is very high, there is scarcity of qualified personnel in our place. Corporate setup has not yet come to our places. We still have got that individual nursing home setup. Insurance facilities are not well established. So what are the benefits of regional anesthesia? It gives excellent anesthesia. There is no question about it. The quality of post-op pain relief is very nice. Better hemodynamic stability is there. Fewer side effects than general anesthesia. There is no polypharmacy, or I not have to bother much about the airway. Then use of opioids and its complications are avoided. You can discharge them earlier. Then you have got ideal, and it's ideal for pediatrics, elderly and high-risk patients. It's very economical. That's the reason I told. Many of the surgeons, they call us to give regional anesthesia because they can save a lot on that. And the same money the patient doesn't save, they collect it for themselves. So that is their reason why they call a regional anesthetist. So you have got an awake patient in the post-op ward. So naturally, again, we can't rely on the sisters to monitor them. When we call up and ask how is the patient, patient is fine, sir. The BP is 50, pulse rate is 50, and BP is around 60, and they don't know which is saturation, which is heart rate. ऊपर का 70 है, नीचे का 90 है करके बोलते. Then I have to think which monitor they have got and what is there. So it starts like that for me. Okay. Then this is very important part in our practices. You can do cases simultaneously. This happens very frequently. Like recently it happened. I was doing a distal radius fixation under a upper limb block. Suddenly the obstetrician came and told that there is a two previous seizure come in labor. Now this orthopedic procedure is going to take at least 2 hours. So what we did is, there was a side room, we pulled out all the things there. There was some old labor table. On the labor table only, I gave spinal, the case was done. What I did was, here on the main OT, I just increased the volume of the beep so that I can hear from there. And I kept on shuttling on once the extraction was over. So this is one of the main advantages of most of anesthetists working in peripheral hospitals. In fact, if there are 2 hospitals across the compound, you can jump the compound wall, go there, finish a case and come back again. And I will not have to ask, the surgeon need not also ask me this question, sir, I need relaxation. Then my answer will be different, we'll go somewhere else. So if you have to practice regionals, your success rate should improve. And how do you do that? Basically, you have to gain the confidence of the patient. Then you have to be good in your anatomy. Your techniques should be better, and you have to have equipments to improve your techniques. Then the drugs, you choose the drugs which are right for that situation. Instead of scolding the staff, you don't know that, you don't know this, because she is not even educated or she is 10th fail or something. You train them. Don't try to blame them, because they don't know they are like that. Whenever you get time, you train them. So this is saturation, why saturation is important, what is blood pressure. If you train, then you have got the thing to scold them. Without teaching them, how can you scold them? If a qualified person comes, you can scold them. But an unqualified person, you should take extra time to teach them. So then you have to be ridiculously persistent on the techniques which if you have to improve, and updating is a must. Or else if I give a block and you can see cobwebs here and cobwebs here, and I'm playing with my mobile and surgeon is waiting when I have to start. So that you have to increase your success rate. So Sushruta told surgery is the first and the highest division of healing art, but no surgery can be done without anesthesia. And Lord Moynihan told the most important person at an operation theatre is a patient for whom surgery may be often one of the most important events of life. So always make that eventful very comfortable for him so that he remembers. Means he, at least when I go out in the market, it's a small place, or else you see, this is a chap who gave anesthesia and didn't work and I was having pain. And over that he collected 1,000 rupees. So you should not get such comments, okay? So what made me learn regional techniques? We had a lot of high-risk patients, diabetic patients, diabetic foot, they are in sepsis, they are not fit for spinal anesthesia also. So I had to learn regional blocks, and all the speakers here, Sandeep, Rushali, they have all contributed for my success. I really am grateful to them. Then it's not ideal to give general anesthesia, then monitoring is not complete, there is limited help. You should see when I am inducing a general anesthesia. One hand I'll be masking, suddenly I'll give propofol. Then I'll come out, then I'll give scoline. There is nobody to help. I'll be just seeing around, then I'll put a tube. In fact, one of the practitioners who is sitting here, he was having difficulty in intubation. He was trying to visualize the larynx, and he told, press the neck, press the neck. Suddenly the assistant came and was pressing the neck of the anesthetist. That is the situation what we face. In fact, that anesthetist is here. And the most important part of regional anesthesia is it's very economical. This was a patient who came, and I gave him regional anesthesia, spinal. He was for a low limb surgery. So, but for some reason he had left his specs in the ward. This chap started insisting that I want specs. Then I had to remove my specs and give it to him. Okay. Then he was very happy. He kept quiet. So these are the patients sometimes we get. If you see the patient only, I should give the OT and run off. That is the situation. Now we try to. I am not interested to do this case. We ask them to go to higher centers. But this old lady, she was telling, I will die here, but I will not go anywhere. So then what I had to do was, I had to give a subclinic perivascular with a superficial cervical plexus. It was for a shoulder surgery, and things went on well. In spite of knowing that it causes phrenic nerve block and all, still I have to do something, because she has given her own consent for death, isn't it? Okay. Then this is a child which Rushali also showed just now. This is a herniatomy. It's an ex-preemie, a poster for herniatomy. Given a caudal, but this caudal I have only given Rushali, not your surgeon. With due regards to the patient, because I had to show these videos, this doesn't look like a peripheral hospital. Over the time I have grilled the surgeons, I have made them to realize what exactly the value for life is, and they have agreed. They agreed. That is the best part for me. It is happily pacified with a pacifier. Now it moves, okay? That means that the patient was awake, okay? See, this is first post-op tracheoesophageal fistula. I have put an epidural catheter through a caudal space, and the child is lying so comfortably. That is the beauty of regional anesthesia. See, you can see the spelling of epidural. Means the person who has done, he is not an educated chap, but he writes epidural. Nobody touches that. And that is the cardiac stability of the patient. Okay? So, attitude matters. Don't have a mind block. Whenever you say I have to give a block, array yaar, that equipment, don't give a thing. Accept the challenges. Be in the uncomfortable zone so that you can progress. Be proactive. Then to conclude, in peripheral setups, it is challenging. It can make a difference. Invest on equipments without expecting immediate returns. Feel proud that you are given a quality care, and regional anesthesia is a boon and bails you out in tough situations. This should not happen. It's a light anesthesia. Okay. Thank you.
That was a very nice, humorous touch to the regional techniques. Dr. Guru is a very close friend of mine, comes from the smallest of the town. But mind you, now he has got an HNS-STEMI plex, he has got an ETO machine of his own, he is going to buy an ultrasound of his own. So that's how you progress in your regional techniques.